please, you should this time. Okay, please.
Okay, fine.
Yeah. Shall I start?
No, wait. It's about to go live. I will give introduction. Okay, you wait. Yeah. So, guys, we are live. Hi, and welcome one time more to this masterclass series. And it's a great thing because under the vision and guidance of Dr. Shilpa, this series has completed 50 sessions on fertility masterclasses. This is the 51st session. Okay, and she is on this mission of creating a complete bank of information on fertility which people can access for free, and I'm very happy that it is helping a lot of people. So thank you, Dr. Shilpa, for this initiative, because had it not been for you, people like us would have never done something like this. So thank you for this. And it is so unfortunate that I have been put against Dr. Shilpa madam to debate on something. I it's so bad. Imagine how much the country will start hating me. Okay, but for the sake of academics, as she has told, uh, I'll do this. Okay, so Dr. Shilpa, you will be speaking on fresh transfers, and you can start. Thank you.
Yeah. Good evening, everyone. I think this is one of the topics which have been debated multiple times in multiple conferences at various platforms, local, state level, international, national, everywhere. And this particular topic, again, I have chosen today with Dr. J, because this is to come to some kind of logical understanding as to what is the way forward, or what is the ideal situation. I know, I mean, these two, like freezing everything and or not freezing anything at all, is like too much of a contrast. And somewhere we have to all come in the middle and agree at some point in time. So what are the factors that we take into consideration? I know the freezing has been one of the greatest advances in assisted reproductive technology, which has helped immense clinicians who can reduce the risk of OHSs. And this has been a life-saving technology, the freezing technique. So in such a good technique which has been developed, or which has been in place successfully over past few years, why are we having this debate as to whether we need to electively freeze all? So I'm not talking about whether freezing is good or bad. So today I'm talking about whether we need to freeze all the embryos in all the IVF patients and then do only frozen embryo transfers, or is there any place where we can do fresh embryo transfer in this era of great vitrification technique which is available, where the embryo recovery is almost like 100%. So here I would like to put in a few points. So when we are doing an IVF, when we are putting an embryo inside a uterine cavity, the whole point, or we are giving a very good chance for that embryo to implant. So I would say the contribution of the embryo in this is around 70%, and the endometrium is about 30%. So the dialogue between the endometrium and the embryo which happens is the one which causes the successful implantation. So for this successful implantation to happen and result in a good clinical live birth rate, that is CLBR, what we aim at, or what is our focus, or what is our goal as a IVF specialist, is to have the highest of the clinical live birth rate. So whether we are able to achieve this by doing the freeze all, or can we have the same results by doing selective freeze all, is the question which is now which is raised. And I would like to tell that this freeze all, or the freezing process, came into picture only because we wanted to prevent OHSs in cases of hyperresponders. And there have been multiple studies in the literature which is available, even the Cochrane reviews which are available, which only talk about this segment of the population who are hyperresponders and who may have a risk of OHSs, and who have done freeze all, and they have found that the clinical live birth rate is better in these set of population. Yes, I mean, of course, I agree with that point, which is very valid. But here I would like to again bring upon two other categories of population, which is the normal responders and poor responders. And of late, we are seeing, especially in metros that I work in the population segment, I see more and more of poor responders. I see more and more of women with diminished ovarian reserve who are older, who come for IVF. So in such situations, the normal responders and in poor responders, I think we should definitely explore the possibility or individualize the patient for fresh embryo transfer. And in my practice, I follow fresh embryo transfer in cases of say like poor responders. If I have two good blastocysts, if the E2 levels are less than 1500, progesterone is less than 1. But in case if there is any variation in these parameters, if the E2 is high or if the progesterone levels are high, of course, I mean, we go for the freezing. And the second thing is when it comes to the costing. So when we do a freeze and then thaw and then do the whole process, that segmental IVF that we do, so the cost of the IVF to the patient is definitely going to be higher. And the time taken for pregnancy. So if we do the freezing and then if we call them and then again if we start the preparation for the endometrium, so many a times we lose out on the time. So if the patient has come in only for an IVF from abroad or from some other place, from a distant place, then I think we should still have this in mind, where we can give the patient an opportunity that we can consider fresh embryo transfer and finish it off as early as possible. So the time taken to get pregnant for that patient will be lesser if we are doing a fresh embryo transfer, of course, when the parameters are right. And then again comes to the expertise of the embryologist and our embryology laboratory workflow. So in these situations, I think now, because there are so many IVF centers and there is a dire need of good embryologists who are very well trained and experts in vitrification, I think that is something which we need to look at. So if the embryologist is really good in this, then of course, I mean, you have decent results. But if you are a person where you don't have access to a good embryologist, again, you can still, like, you know, if the parameters fit in, you can still consider doing a fresh embryo transfer. So then there are other things like, say, the obstetric and perinatal outcomes. So in fresh embryo transfers where there is already a corpus luteum which is existing, this will reduce the risk of preeclampsia, reduce the risk of the macrosomia to the baby. And this is kind of like, you know, an obstetric outcome which is quite good. So since I do a lot of obstetrics and all my IVF patients, like, you know, at least 50% of them deliver with me. So I would like my patient who has become pregnant with IVF to have a smooth journey in their pregnancy. So again, fresh embryo transfer, doing it with the presence of corpus luteum in situ will reduce the risk of preeclampsia. So finally, I would like to again come back and tell you that, like, we should go in for a selective freezing and not elective freezing of all patients. Yes, I mean, only in hyper responders, I advocate or I recommend to do the freezing where there is a risk of OHSS. But in other cases, I don't see any difference in the cumulative live birth rate or any difference in any other outcomes. And I think there are more studies which needs to be done to say that freezing and doing a frozen embryo transfer scores over fresh embryo transfer. Yeah, so I think I have put in all my points in here. So probably one more point is, I think the only role where freezing helps is when you do a PGT, where you're doing a biopsy and waiting for the good embryo to be transferred. I think the role is only in those situations and nowhere else. Yeah, over to you, sir. I think you can take it forward.
No, I mean, see, what you mentioned that freezing should only be reserved for hyper responders, and in normo responders and poor responders, one can try doing a fresh cycle in order to avoid the cost. I mean, the cost spiking up, the time to pregnancy going down. With that, I think there is a very big problem which people should understand in this. that majority of the cycles which are done for domestic patients is for Indian patients are cycles which are done with antagonist. Okay. A prolonged exposure of antagonist to the endometrium more than 2 days, okay, is going to definitely cause a negative effect of implantation over that endometrium. That is the first thing which you should understand, even if it is for a normal responder or a poor responder. All right. Coming specifically to the poor responders, please keep this in mind that when you have a poor responder, you don't really know how many blastocyst embryos this poor responder is going to form in that fresh cycle of stimulation. What people normally do is, if it is a day 2, day 3 embryo and two such day 2, day 3 embryos are formed, the laboratory is not confident enough of forming a blastocyst. In that situation, they go ahead and do a fresh transfer. Okay. Second, there is an inherent problem as far as the LH pulsatility is concerned. Okay. When you have a fresh transfer which is planned because of the HMG induced stimulation, we've been discussing this in our master classes, and everybody would have learned this by now, that when you give HMGs for stimulation, you will have an abnormal LH pulse. This abnormal LH pulse is going to cause a defective corpus luteum. This defective corpus luteum is going to give rise to the need to give a prolonged luteal phase support. Okay. And you can completely avoid this when you do a modified natural cycle in an FET. Okay. Most of the FETs, frozen embryo transfers, let's say 50 to 60% of the FETs in almost every place, hopefully, have shifted to modified natural cycle preparations. And if they've shifted to modified natural cycle preparations, the concern which Shilpa madam raised, being a busy obstetrician, that there are macrosomic babies and preeclampsia and all these things which happen with HRT stimulated FET protocols. They are not to be seen with modified natural cycles because it is a natural corpus luteum which you have out of it. Okay. And when you have a natural corpus luteum, you can completely avoid that problem as well. Okay. The other thing, as far as doing freeze-all, and I think it is important, is because many a times you may have aberrant polyps which form in the endometrium during stimulation of many of these patients due to excessive estrogen which happens. Okay. And in that type of a situation, planning a fresh transfer it's not a very viable option. You are definitely reducing the success rate of that patient for becoming pregnant when you are transferring the embryo in a non-synchronized endometrium and in an endometrium which has a pathology. Okay. And third, when you do a fresh cycle, unless the way in which you give your antagonist is well defined, your endometrium to embryo asynchrony is very big. Okay. As a result of which, if you were to do a planned FET for every patient, you will definitely add 4 to 5% to your success rates, unless the patient is going out of India. Like, unless the patient has a very fixed amount of time to finish the IVF cycle, that's a different story. But apart from this, if you try to do something like this, where you are, what I mentioned, where you are trying to do a fresh cycle for everyone, you are reducing the success rate of that particular patient or couple by average of 4 to 5% over a prolonged period of time. Okay. And finally, see, vitrification is a very standard technique now. Vitrification doesn't add to the cost. Okay. The total cost of doing a vitrification for a particular embryo, one embryo. Okay. I'm talking of one blastocyst embryo, not one day 3. So I'm talking of a single straw which is used. Okay. So the total cost for doing vitrification for a single straw, including the cryotop, okay, the one in which you place your straw, okay, does not exceed 2000 rupees. Okay. And in today's time and age, 2000 rupees doesn't really matter to most of the patients. This is including the labware, including the vitrification media and thawing media. Okay. So it doesn't really add to the cost of the patient. One must keep that in mind. With more and more and more IVF laboratories which are going to come and mushroom in the country, one thing is for certain, that this is going to become a very important skill, vitrification of the embryo and thawing them. Okay. When you vitrify and when you thaw these embryos, the huge advantage which you mentioned already is about doing genetic testing. And as we go more and more in the future, the number of patients who will opt for elective genetic testing for their embryos is going to go up. There is no doubt in that. The number of patients who will benefit with genetic testing is also going to go up, because so many of the couples undergo evaluation for karyotyping. And if you have a karyotyping which is reported, even those smallest of the aberrations, if you do a genetic counseling on this, there is one line which is included is PGTA may be recommended. Okay. And if PGTA may be recommended, the couple really wants to consider that. So in that situation, you can't really do a fresh transfer. Okay. So in my practice, we reserve fresh transfers only for patients who have come from outside of India, who are in India for a limited number of days and who have to finish the entire IVF cycle in that span, and they have to go back to their home country. These are the only patients for whom we reserve a fresh transfer. Every other patient, even if they are located outside of Mumbai, these are the patients who are going to go in for a frozen transfer only.
So, see, you're talking about like, your decision is based on the time factor of the patient. So, where is
Yeah.
the science in this? I mean, where is your scientific basis for doing it? I mean, what is your success rate in these patients who come from abroad? And I know you get a lot of patients from, I think, outside India. So, what is
Yeah.
your data? What does it say?
No, when we write it down for the patient, we tell them that when you are doing a fresh transfer, your success rate is 3 to 5% lesser than frozen transfer. Okay, though there are many papers which tell that no, fresh and frozen doesn't really make such a big difference. I think there is this 3 to 5% difference which comes in the patients. There are some people who are going to become pregnant and they are great. There are some people who are not going to become pregnant, but this needs to be given to them in writing. Okay, prior to planning it, prior to doing a fresh transfer for them. Okay.
That is
So
irrespective of their response, like whether they are PCO, whether they are normal responders or even poor responders, you are saying that the results are going to be lesser in fresh transfers. You are going to give it in the documented.
we always give it, madam. Yeah, our documentation is very clearly stating that if you are to do a fresh transfer, your result is 3 to 5% lesser than frozen transfer. Simple. Okay. And the patients who don't have much time, they accept it, that it's okay, 3%, 5% less, but we have this much time, we want to do it and go back. Okay. The others who are located in India, they don't mind spending that 20 days more, maybe 30 days more. Okay. And coming in and doing a FET. They absolutely don't mind doing that. Plus, one must remember one thing. See, when we try to discuss all these papers, no, fresh transfer, frozen transfer, and all this, these are papers which are done abroad and in countries outside India. The policy of drugs is absolutely standardized. Okay, absolutely standardized. So every IVF clinic in a particular country will be using only a particular drug. It is not like our country where the same IVF clinics has 4 HMGs stored with it based on the category of patients. There is no such thing which exists in most of the IVF centers abroad. Okay, it is a government regulated HMG which they will be using. It is a government regulated REC FSH which they will be using. Government regulated antagonist which they will use. Government recommended trigger which they will use. So the factors, the amount of variables which they have in stimulation is way more less than the amount of variables which we have in our cycles. Okay. All of us have a huge amount of variables because we do not have standardized HMGs or REC FSHs in our country. All right. So
Okay.
please keep that in mind.
Yeah. So, but what is the scenario in cases of, like, say, tier 2 cities which are mushrooming, where there are lots of IVF centers who are mushrooming and who are still, like, I think in their very early period of their, say, IVF journey. So, probably in the past, say, 3-4 years, we see a sudden jump in the number of IVF centers in these cities, and the number of embryologists is not equivalent. So they have their traveling embryologists and
They will all adopt. They will all adapt to it. The more number of traveling embryologists who come, it's simple economics, okay, of demand and supply. When there is a demand for a particular thing, initially there will be short supply, then the supply will exceed for a temporary period of time, and then there will be a plateau. Okay, so it's a part of the game. Person who wants to set up a IVF unit in a tier 2 city or a tier 1 city or a tier 3 city or whatever it is, they already know everything about it, and they are taking the plunge knowing all these things. It is not that somebody puts up a lab and then finds an embryologist. Okay, so such type of things don't really happen. People have to go through it for their initial few cycles, and once there is a standardization in their cycles, I think freezing and vitrification and everything gets standardized for everyone.
Yeah, but see, then again, you're talking about like, maintaining those embryos in their laboratory with the right kind of people and the right conditions. And also you're talking about, say, people are not doing like 150 cycles like you are doing. People are doing like, on an average around 5 to 6 cycles in a month. Okay. So in these situations, 5 to 6 cycles where the media cost and the freezing media cost and all may not be like 2,000 rupees, like how the company
No,
will
no,
you.
it is actually the same, because what typically happens is these media have an expiry of 6 to 8 months. In fact, the vitrification and thawing media have an expiry of more than 1 year. Okay, so even if you buy the vial properly and preserve it in cold storage properly, there is no denaturation in the modern vitrification and thawing media. So that cost factor is actually the same almost everywhere. And what typically happens, as you mentioned, madam, people who are doing 5 to 7, 10 cycles, let's say people who are doing single digit IVF cycles in a month, for them it is going to be a much more wiser option to club everything and do a batch IVF. Because when you want to really cut your cost down, you just do it as a batch. When you do it as a batch, everything will get synchronized. Results are going to be the same, absolutely the same. Okay, and patients will benefit and the clinician will benefit. All people will benefit.
Yeah. So I think, yeah, I don't agree with regard to like, if we get two top quality blastocysts and if the endometrium is good, if the progesterone level is less than 1 and if the E2 is less than say 1,500, I think, oh, what is your like, argument for that? Like, why do you think that we should not do the fresh transfer? Because it's the same, forget about the antag. See, even when we give antag, see, you give a half dose antag and still like, I have done it multiple times and people have conceived. You're talking about more
Yeah.
than 2 days of antag. So
Yeah.
ideally it will take about 4 to 5 days of antag till we reach the trigger. So these
Correct.
4 to 5 days antag, I mean, the half-life is quite okay, but I don't see
16
any,
hours.
yeah, so I don't see any reason why this should cause a problem in the implantation. See, I will tell you frankly, I mean, for the longest of time, I mean, I have given antag even in my the HRT cycle of FETs, okay, and the results have been the same. So the reason why I didn't stop using the antag was only because I was scared that where my results will go down because I'm getting good results. So I just wanted to follow the same thing. So I don't think like, antag really matters as to what you said in terms of changing or altering the endometrial milieu for implantation. But apart from that, do you have any other points, valid points, which can tell people that you should not do it for this reason in
No,
cases
no,
of...
I already mentioned that when you have an HMG induced stimulation for any patient,
Hmm.
okay, there is an abnormal LH pulse. We've discussed this before. This abnormal LH pulse itself causes a defective corpus luteum. Okay, when you have a defective corpus luteum, you need a very severe or a very strong, luteal phase support. As simple as this. Okay, and this when you want to do it in a fresh cycle. Okay, when you try to do this in a fresh cycle, definitely there is a high amount of endometrial asynchronization. Even if it looks good, as you mentioned, even if the reports are good, as you mentioned, okay, still there is a lot of asynchrony. Because
See,
there
but
is asynchrony,
yeah.
we should avoid it just to save that 30 days.
Yeah, but the implantation window in cases of the stimulated cycle is quite wide. And we are talking about the asynchrony. If only if it is more than 3 days, only then the implantation will be affected. So if it is within that 3 days time, I don't think the implantation like, really matters. And also like if you're giving like 2 or 3 combination progesterone in majority of the IVF cycles by majority of the IVF consultants. So I don't think there can be anything more. Like the only thing left is for the patient to take bath in progesterone soap. That's the only thing I think that is left. So where this amount of luteal support you think is still not going to be enough when there is a defective corpus luteum? I don't think so. I mean,
The amount of progesterone receptors are not going to change irrespective of the amount of external dose of progesterone which you give. That is the first thing. So even if you give her a bath in progesterone soap, the endometrium will absorb only that much progesterone, as many receptors as it has. Okay, that is the first thing. Second, when you say that when you give a double luteal phase support, it doesn't really matter, right? It's going to be fine. But this is the only hormone which we are trying to argue upon, madam. Okay, when you are having a defective corpus luteum, there are so many other hormones which are secreted, which has been proven in a modified natural cycle, like relaxins and VEGF, and so many other 20, 30 hormones have activins. All these hormones have been declared to be very, very important in implantation. We don't really know what is the outcome of a defective corpus luteum as far as release of these hormones is concerned. Correct. So when we don't really know this, okay, and I have to make somebody wait just 30 days. Okay. I don't mind waiting, making all of them wait. Okay. Freezing that embryo because I have a very good outcome with the freeze and thaw protocol. Okay. And then transferring them when I know that when I do a modified natural cycle after that for these patients, normal responders or hyper responders. Okay. I will get an excellent outcome. I'll get a good corpus luteum. I will be able to trigger this corpus luteum and give them the best possible endometrium. So if in case it is a matter of just 5,000 rupees or less, okay, and 30 days or less, then I don't mind waiting for these patients, for all these patients. That's the reason.
Yeah.
Because no, madam, ultimately IVF is a game of outcomes.
Yes.
And IVF is a game where one extra patient who becomes pregnant with your treatment, one extra patient. And if that patient is happy with you, if that patient is happy that, you have been non-commercial, you've been you are not a package guy types that you have 2 IVF package and 3 IVF package and all these things. If you are not that, see, people are not fools. Okay, they understand everything. They understand everything. Okay, so if you think you are doing a great service by doing a free IVF camp, people are coming just to take second opinion for free. Okay, and if you think that you will obtain some CRM data from the mobile numbers which they've written down, it's very easy for people to block these calls. People have become very intelligent. All right. So, banking on their intelligence. Okay. If you give them an option like this, patients know that, okay, this is a part of the package. Doctor is not surcharging us for anything. He just wants us to have 5% more pregnancies. 5% more pregnancies is a big thing when you are doing 1,000 IVF cycles.
Yeah, of course. See, that is what I'm trying to tell you. See, if the freezing and thawing process, if the embryologist is not confident, or if if it is not standardized in their unit, and if they're still struggling, and if it is not a great quality blastocyst, if it is so blastocyst, and if you are freezing and then thawing, and it will definitely affect the recovery of that blastocyst. So why miss out on that chance of putting that decent quality blastocyst during the fresh embryo, during the transfer, and give the patient a chance. See,
Yeah. It's a valid point for a sake of an argument. But then, if somebody does not have the technical ability to freeze a particular blastocyst, right, that particular person in today's time doesn't even deserve the credit to be a embryologist, because this is the most important skill which an embryologist should know. Okay, vitrification and thawing. Most important. This
that
this is
is
not a workshop skill anymore. It is like a diagnostic histolab for a gynac. It is that
no.
important.
See, diagnostic histrolab also, how many percentage do you think are able to do it? I mean, only about say 75%, 25% are still they are a little intimidated by even putting that Very's needle or putting that primary
Yeah.
probe. And similarly, I mean, embryologists, yes, I mean, they come with great the CVs and with high recommendations. But when you actually see them do it, the recovery is not the same with everyone. So in such situations, I think especially in cases where we are using milder IVF stimulations, where we are using the stimulations for say tubal blocks, where IVF is just where we are doing the fertilization outside the body, I think we have a fair amount of scope to explore the option of FAT. I mean, that's what I do in my practice. I mean, I don't know, we can go on arguing forever, but yeah, I mean, this is something which the consultant should individualize and take it according to their circumstance, and take all the points put up by Dr. J, which I think is what do you say, the dream situation, which any person will have: a great embryology team, a great stimulation protocol, and the patients who listens to you, and also I think with a very good backup of say the biochemistry lab, whatever. I think that is something which is an ideal situation. situation where we can't really expect of it with all the consultants and in all the places. So that is where I think our the debate today would be more relevant, where we can't be in that ideal situation. And
Madam, I want to tell one thing. Nobody starts off being ideal. Everybody progresses to fill one plug at a time. Okay. We never started with a biochemistry laboratory in-house. We never did that. We never had the resources. Okay. So as you keep on reinvesting in your own circumstances, you will redefine your own outcomes. Unfortunately, that is what majority of the people don't do. Okay, majority of the people become very complacent once they've reached a particular zone of outcomes, beyond which they feel that reinvestment into that particular system may or may not give them an ROI. Okay. And when they start thinking of it as a manner of ROI, they'll almost always end up making a mistake, because as far as healthcare is concerned, you have a huge trajectory of unrecognized ROI. Huge trajectory. You know, if you do one good laparoscopic surgery for somebody, he or she might send a relative from somewhere to do onco surgery with you. You do that nicely, you will get their friend whom they met at a chemotherapy guy for doing egg freezing with you. If you do that nicely, you will get somebody who is in their college and smoking and has a low sperm count with oligospermia for you. So that is something which one cannot really imbibe.
Yeah, that is like if you're giving the end-to-end services. Okay, so if you are only...
So nobody gives end-to-end to start off with. We never did obstetrics for the first 1 year of practice. I did only less than 100 laparoscopies in the first year of my practice, because I had no resources and nobody would believe that I am doing laparoscopy, right? But IVF was something which I could set up on my own. So I started with IVF. Keeping laparoscopy, the first time I made some money in my life, I bought a 3D laparoscope, because I knew that, I am going to do good things with laparoscope. Then when I made money, I did not spend it. I bought a new hospital because I needed more space. Then when I made some more money, I bought the biochemistry lab. It just keeps on progressing like this, right? And till you follow that cycle, your circle of accomplishments will keep on getting bigger. The day you cut it, your circle of accomplishment will stay the same.
True. I think, these are wonderful insights into our practice, what we need to inculcate, and probably how we need to look at it from a very varied angles. Of course, I think, the debate finally, I think we should take a poll in our groups to ask, once they have seen the class, as to what their final conclusion was and what they would like to follow. But I think it was great to listen to your side of the perspective of doing this. It was wonderful. Thank you. Anything else you would want to add?
No, madam.
Thank you, sir. Thank you so much for putting up your points. It was very, very good. Thank you. Thank you, everybody, for joining in. We'll see you tomorrow.